Hi students, welcome to the next session in oral pathology. We are going to discuss about epithelial lesions of the oral cavity. Okay, so epithelial lesions of the oral cavity, we have three groups to study actually. We will divide it into three groups and study. How to study epithelial lesions is that epithelial lesions consist of benign lesions. One category is the benign lesions. One category is malignant lesions. And there is one thing before this malignancy, that is pre-malignancy. Okay, so we have lesions in the oral cavity that is not a benign thing and that is not yet made malignant, that is not yet malignant, but in the verge of malignancy, that we call it as pre-malignant lesions or pre-malignant conditions. Okay, so pre-malignant lesions and pre-malignant conditions are very old, outdated term. Okay, now what we call them is oral potentially malignant disorder, OPMD. Okay, so OPMD is the new name for this. This is the term we use now. Pre-malignant lesion and condition is a very old outdated term. Now we don't use that. Okay, but in still if you work out previous year, I mean very old question papers, you can see this term. Okay, and see benign lesions, we have a different video on benign lesions of the oral cavity. Okay, and we have different videos on malignant lesions of oral cavity. In this video we will discuss about this OPMDs, oral potentially malignant disorders. So there are so many questions they ask from this OPMDs, because OPMD is a very important portion of your NEET and your NSCT MCQ exams. Okay, because the world is concerned about OPMDs. Okay, the world is concerned about growing oral cancers. The world is concerned about this oral potentially malignant disorders, how to diagnose and how to treat things and how to prevent cancer. Okay, so this is very important. So let's see what is there in OPMD. See, so many things are there in this OPMDs, which is revised every year. Okay, every year they revise it in the WHO classifications. So I am giving you the latest classification of WHO 2022. This you may not find in your textbooks. Okay, so this is latest which I have listed out here. You know, there are so many potentially malignant disorders. You may have heard about leukoplakia. The first one is very familiar to you, right? Leukoplakia, that is a white lesion of your oral cavity which is related to your smoking, and it is non-scrapable lesions and all this you may have learned. There's other OPMD called proliferative verrucous leukoplakia. So many questions in this leukoplakia and proliferative verrucous leukoplakia. We will discuss that and you will see that in the question papers also when we work out the question. Erythroplakia, that is a red lesion. Oral submucous fibrosis, we have another video on oral submucous fibrosis which I have discussed in detail. And oral lichen planus is considered a pre-malignant lesion. Okay, pre-malignant disorder or potentially malignant disorder. Oral lichen planus actually it's a what to say, it usually doesn't show any dysplastic features. But it is considered a OPMD. Actinic cheilitis, palatal changes in reverse smoking that we will see now. Okay, lupus, oral lupus erythematosus. Okay, that is lupus is also considered. And smokeless tobacco keratosis, tobacco pouch keratosis, disc keratosis congenita. Now, you know something in 2020 classification. Okay, in new things were included in the 2020 time. Pre-malignant lesion, they had this oral lichenoid lesion and oral graft versus host disease. This oral lichenoid lesion and oral graft versus host disease was considered potentially malignant and they were included. But interesting thing is, what you have to learn is that in 2022 they had come up with a new lesion. Okay, and that is HPV associated dysplasia, human papilloma virus associated dysplasia. Kindly note, because this we are expecting in the upcoming NEET examinations, because this is being asked now in the INACET senior resident papers. Okay, INACET SR papers, you can see this question. So we are expecting that they will definitely ask this in your NEET examination. Just one thing you have to know: the newly introduced PMD is HPV associated dysplasia. Okay, so we will see what to study in this, what are the features in this. Now it is very simple, you know, to tell a OPMD, tell a lesion to be a OPMD, we should see dysplasia. Okay, dysplasia. Now you know that a normal oral mucosa, we have a normal oral mucosa, And when this normal mucosa is subjected to insult, like you're smoking or any tobacco products or alcohol, okay, so when they are subjected to this insult, what happens is that there are some kind of changes will occur in this mucosa, right? In the epithelium, some changes start to occur. That changes will occur in the cellular level, in the cells. Okay, in the cells, the changes will happen. That is, changes occurring in the cells. Okay, and sometimes you know that these changes can be seen in the what architecture of your epithelium, right? How your normal epithelium is, you have stratum basale, stratum spinosum, stratum granulosum, and your stratum corneum. So that is the architecture. Now, what about this stratum corneum coming near your stratum basale? Means some kind of keratinization occur in the basal region, or some kind of keratinization occur in the spinous region. Means the architecture has changed, right? The architecture has changed. So there are two features. There is architectural changes and cellular changes. Okay, architectural changes and the cellular changes means there is some changes occurring in the oral mucosa due to this insult. We are giving insult here, tobacco, mostly tobacco, okay, tobacco or alcohol or any insult it be. There will be cellular changes and architectural changes. When there is cellular changes and architecture changes happening, we call that this epithelium is undergoing dysplasia. Dysplasia is a red signal. Okay, it's a red signal. It's alert. Okay, it's alerting. Okay, now dysplasia has started. Anytime if you are not checking this dysplasia, it will change to carcinoma. Okay, it will change to carcinoma. Okay, so that is your what is happening in or potentially malignant disorders. The dysplasia, if the dysplasia, you see, there are three types of dysplasia. Okay, if I have epithelium here, I am drawing the epithelium here, and yeah, this is the epithelium, this is the connective tissue. If the dysplasia is only in this lower part, lower 1/3 of the epithelium, we call it mild dysplasia. Okay, if the dysplastic features are seen only, there is so many features. There are cellular features and architectural features. If they are seen only in the lower 1/3, we call it mild dysplasia. If it extends till the 2/3 of the epithelial thickness, we call it moderate dysplasia. And if it is extending till the top, if the dysplastic features are seen till top or full the thickness of the epithelium, we call it severe dysplasia. Okay, so dysplasia can be three based on the location. If it is occurring in the lower 1/3, we call it mild. Till the 2/3, we call it moderate, and till it the surface, we call it severe. And then, if still this person is not checking it, what happens? It will turn to squamous cell carcinoma. Okay, squamous cell carcinoma. It will turn to a cancer. So this is what really happening here. Now, what are the cellular and architectural features? Can you see this? There are so many cellular and architectural features. You don't need to buy heart. Please, they won't ask you anything in this. I'm just giving you an idea of what are the changes occurring in the cell when there is dysplasia. Okay, you can very simply see what are the architectural features and cytological features. You can take a screenshot and read it sometimes. Okay, and you can see the changes. Okay, stratificational changes, basal cell polarity changes, rete ridges will become large, bulbous, and drop. Okay, keratin pearls in the rete ridges. Okay. And cell become less cohesive, means cell will detach from each other. If you see the cell cytology, if you see inside a cell you have cell, the cytoplasm and the nucleus. So there is size of this nucleus get large, nuclear shape will change, cell will be larger. That's called a pleomorphism. Cell will change, the NC ratio will change. Normal nucleus to cytoplasmic ratio. What is the normal nucleus to cytoplasmic ratio? It is 1:4. It means 1 part of nucleus and 4 part of cytoplasm. It will become 1:2. Okay, means that, or 1:1. Means nucleus and cytoplasm, nucleus is this big as cytoplasm. Okay, they are equal. Means that is NC ratio. Mitotic figures, there will be mitotic figures. Hyperchromatasia means darker color. So all these are the features of dysplasia. So when it start appearing, we call it there is dysplasia. So you can see in this picture, I can see that this lower 1/3 portion of this epithelium, Okay, they are having a dark color nucleus. You can see the dark nucleus here, hyperchromatic nucleus. Okay, and this is basilar hyperplasia. So features are seen in the lower one third of this epithelium. In the top area port, there is nothing. The upper part is fine. The only the lower one third is having this defects. So it is a picture of a mild dysplasia. Doesn't matter. So let's see each potential malignant disorder. Can you see in this picture? You have a white lesion on the cheek region, and that lesion, which is non-scrapable, we have a white presentation, white lesion, and this white lesion is mainly seen on the buccal mucosa, tongue, anywhere in the oral cavity. You can see most commonly it starts with the buccal mucosa, and that white lesion is which is non-scrapable. If you try to scrape it, it will not come out. Okay, so it is called leukoplakia. Leukoplakia. Okay, leukoplakia is a homogeneous, or it is just a small, it is just a smooth white lesion on the oral cavity. You can see this. Okay, so leukoplakia, what is giving this white color? It is more of keratin. Okay, the keratinization, more of keratosis. Okay, hyperkeratosis. Hyperkeratosis. Hyperkeratosis is giving this white color in the leukoplakia. Okay, so this is leukoplakia. And what's the reason for leukoplakia? There are so many reasons. There is tobacco is the main reason, alcohol, and what other many other reasons. In if you're having more of spices related, okay, trauma related, it can come in many ways, but most common reason is your tobacco usage, habitual usage. Okay, so that is leukoplakia. Now leukoplakia, according to the clinical presentation, they can be smooth. Okay, it can be smooth. If it is very smooth white in color, we call it homogeneous leukoplakia. If you have some kind of small growth in it, we call it nodular leukoplakia. Nodular growth, if you have small nodules in it, we call it nodular leukoplakia. And if this white area has some red areas in between, okay, if this white area has some red areas in between, it is called a speckled leukoplakia. Okay, so if there is white and red areas, okay, then we call it as speckled leukoplakia. And if this white lesion is growing outside, it is growing, okay, it is very thick and growing, thick, and it is proliferating, we call it proliferative verrucous leukoplakia. That is PVL. It is proliferative verrucous leukoplakia. Okay, now what is the peculiarity of this verrucous leukoplakia? Can you see in this picture? So this is also a leukoplakia. I think you can see this picture. Can you see? It is very corrugated surface. See the thickness there. Okay, that white areas, that keratin, it is growing, or it is growing out, proliferating out. Okay, that is called proliferative verrucous leukoplakia. Okay, histology is not that important. You don't want to go to the histology. And what is the speciality of this proliferative verrucous leukoplakia? You know, homogeneous leukoplakia is okay. How can it will not turn into malignancy much. Okay, it will not, means only less than 1% risk is there that homogeneous leukoplakia turn into malignancy. And if you ask the patient to stop smoking, stop the tobacco habit, this homogeneous leukoplakia will revert back. Okay, it will try to heal by its own. But if in nodular and speckled leukoplakia, the malignant risk just increases, because that redness will give an increased malignancy. 3 to 6% there is risk of malignancy. Okay, risk of malignancy, its malignant transformation risk is increased. And you know, proliferative verrucous leukoplakia is the most dangerous, most or highest risk. Okay, I will tell that the proliferative verrucous leukoplakia has nearly 40 to 100% risk of malignant transformation. Okay, so PVL is the highest risk. So you know, there is each of this potentially malignant disorder has a risk of malignant transformation, and that is a very important question area. Okay, very important question area. We will see the question, and then you will understand. And see, this is a red lesion. Here in this picture, you can see a red area. This is called erythroplakia. Erythroplakia is a red lesions. They are red lesions, and they also have a tendency for malignant transformation. Erythroplakia usually comes in the floor of mouth, and floor of the mouth, any lesion, any pre-malignant disorder, if it comes in the floor of mouth, it is very worst. Okay, very worst prognosis. So there was a question in INACT. In INACT, there was a question, worst prognosis. Worst prognosis is seen in lesions on. Okay, floor of mouth is a very worst place. Okay, so there is higher chance that floor of mouth lesions will transform to malignancy, and erythroplakia is very what have a tendency of this erythroplakia to come in the floor of mouth. Most common site, it usually comes in the floor of mouth. Okay, and the malignant transformation of this erythroplakia is nearly 14 to 50 percentage is the malignant transformation. Okay, malignant transformation. So erythroplakia has a 40 to 50 percentage chance of malignant transformation. And this picture, okay, the next one, this is another pre-malignant disorder that you can see in this picture. You can see that there is small pinpoint what structures there. Can you see, appreciate in this picture? This is called smoker's palate. Smoker's palate. Okay, or reverse smoking palate, the palate due to reverse smoking, or reverse smoking changes in the palate. Okay, this is called smoker's palate, and you can see small depression. They are all what enlarged minor salivary glands. Okay, because of the smoking, these are all minor salivary glands which get enlarged. This is the condition called smoker's palate. Okay, nicotinea palatii, or palatal changes due to reverse smoking. Okay, palatal changes due to reverse smoking. Okay, because this is an IBQ. I showed this image because this is an image based question. They ask you identify the abnormality or identify the lesion depicted in this picture. Okay, so I have seen this question being asked as an image based question in many question papers. Okay, so just see, it is very simple. In the palate you can see small eruptions like thing. Okay, they are nothing but your enlarged minor salivary gland orifices. Okay, that orifices of the minor salivary gland is enlarged due to heat related changes or palatal changes due to reverse smoking. This is also a condition which can transform to malignancy. So there are so many questions being asked based on malignant transformation. Okay, so Neville, in your Neville, this is taken from your Neville actually. Okay, so in the Neville there is a table, wonderful table given. Okay, where they discuss which is having maximum malignant transformation. Okay, so in the question they will ask you which among the following has maximum malignant transformation. You can see that the proliferative verrucous leukoplakia, that is having a highest malignant transformation. Then comes your reverse smoking. Okay, nicotinea palatinus in reverse smoking. That's just now what we saw the picture. Erythroplakia, your OSMF, oral submucous fibrosis, then comes below that. We will discuss OSMF in another video. You can write erythroleukoplakia. This erythroleukoplakia is what we call speckled. Okay, and then granular leukoplakia, that is a nodular or granular leukoplakia, smooth leukoplakias. Okay, and so you can see that smooth thin leukoplakia is having the least one, that is a homogeneous. Okay, so lichen planus somewhere comes here, lichen planus, and it is also a questionable thing. But from this you can see that PVL, always remember proliferative verrucous leukoplakia. So many question papers they have asked this proliferative verrucous leukoplakia. Okay, so this is the malignant transformation risk. I hope you understood the pre-malignant disorders or potentially malignant disorders, different things here. HPV induced dysplasia, you don't want to go much detail into this HPV induced dysplasia because it is recently induced. They won't ask you much histology about all these things. What they ask you is malignant transformation. Okay, so I hope this is clear. See you in the next video with a new topic.